So guys, we'll be moving on to our next part, gastroesophageal reflux disease. Okay. So gastroesophageal reflux disease. When you're talking about that, what will happen is there is some kind of a reflux from the stomach to the esophagus. So just a simple idea for you to keep in mind. So there's an acid reflux. Okay. So before coming to the signs and symptoms and diagnosis, you should understand about the lower esophageal sphincter. Okay. So what happens is in the normal physiology between swallows, the muscles of the esophagus are relaxed, except those of the sphincters. The lower esophageal sphincter remains closed due to the unique property of the muscle, and it relaxes when swallowing is initiated. Okay. So these transient lower esophageal sphincter relaxations are part of the normal physiology. Okay. But in GORD patients, this occur more frequently. Usually normal people, there is some amount of reflux. It is a small amount actually. Okay. But when large amounts of reflux happens due to these frequent relaxations of the esophageal sphincter, what happens is there is an acid reflux, and that reflux itself can irritate the lining of your esophagus. Okay. So actually what happens here is when the intra-abdominal pressure rises, the acid reflux is being more facilitated. So when the intra-abdominal pressure rises, so acid itself will get backwashed into the lining of the esophagus, and the lining of the esophagus will get irritated. Okay. Usually this esophagus has a particular mucosal defense mechanism. Okay. So the surface of the esophagus, if we get, there is a bicarbonate trap layer, but it's a weak buffering mechanism compared to the stomach and duodenum. So the epithelium, if we see epithelial surface of the esophagus, okay. So what will happen is it can lead, when there is an acid reflux, there will be a condition called esophagitis that can damage the lining or the epithelium, and it can increase the level of H plus ion diffusion, and also it can increase the level of cellular damage. So because the pH will be very low. Okay. And so there are also certain factors that can be associated with the gastroesophageal reflux. So anything which can increase the intra-abdominal pressure can cause this GORD. So in cases of pregnancy, obesity, and if you eat a large meal, and cigarette smoking, and also if the patient is on drugs like antimuscarinic drugs or calcium channel blockers, or if the patient is having a hiatus hernia. Okay, so what will happen in this hiatus hernia is there are actually two types: sliding hiatus hernia and the rolling type of hernia, rolling or the paraesophageal hernia. So in the sliding type of hiatus hernia, what you have is the esophageal gastro junction will, and part of the stomach will slide through the hiatus so that it lies above the level of the diaphragm. Okay. Usually sliding hiatus hernia will produce no symptoms. Okay. But the symptoms are mainly due to if the symptoms occur, the symptoms are mainly due to the reflux. So, rolling or paraesophageal hernia, part of the fundus of the stomach is also prolapsed through the hiatus, okay, alongside the esophagus. So what will happen there is the low esophageal sphincter will lie below the diaphragm. Okay. So these are two types of hernias which can predispose to GORD. Understood? Okay. So patients might come across signs and symptoms like heartburn. Okay. Usually this burning is aggravated by bending. Okay. And stooping or lying down, or when the patient is lying down. Okay. And also this heartburn is relieved by oral antacids. Okay. Sometimes the patient might complain of pain while drinking these hot liquids or alcohol. They might complain of this heartburn. Okay. And also the patient might experience regurgitation of food and acid into the mouth, particularly when they're lying flat. Understood? So, and soon after eating a spicy meal, they can have these hiccups or a chronic cough during sleep. So, GORD, the diagnosis is mainly a clinical diagnosis. So, ambulatory reflux monitoring or pH monitoring of the esophagus will help to determine the presence of esophageal acid exposure and also the reflux frequency. Understood? So the management is also mainly conservative. You can, for morbidly obese patients, you can go for weight loss, and you can avoid meals 2 to 3 hours before bedtime. Okay. And you can avoid triggers like alcohol, acidic and spicy foods. But if after conservative management, if the patient is still unresponsive, we can start an 8-week course of a proton pump inhibitor. Okay, like omeprazole, you can start. But remember, proton pump inhibitor should be administered 30 to 60 minutes before meal for a maximum pH control. Okay, so that's all for GORD. Let's move on to peptic ulcers. Okay, so this is again an easy topic. Peptic ulcer disease. Here we'll be talking about two types of ulcers, the gastric ulcer and the duodenal ulcer. So peptic ulcer disease, what will happen is there is a break in the epithelial layer which can penetrate down to the muscularis mucosa. So it can either happen in the stomach, if so we call it as a gastric ulcer, or it can happen in the duodenum, then we call it as a duodenal ulcer. So again, when there's a break in the epithelial surface penetrating down to muscularis mucosa, there will be an acid irritation as well. So when the acidic chyme reach the duodenum, again there's a irritation as well. So what will happen? Inflammatory cells come here and there will be a fibrous base. Sometimes these super breaks in the epithelium will be confined to the mucosa. In that case, we call it as an erosion. Okay. So as usual, so there is irritation, gastric irritation caused by acid. In that case, the patient might come up with a recurrent burning epigastric pain. So duodenal ulcers, the pain is worst in the night and when fasting, mostly due to increased acid secretion. The pain is mainly due to increased acid secretion. So during the night hours or when you're sleeping, you'll be fasting. So more acid will be secreted. The stomach will be empty. So in that case, there will be increased acid secretion and the breaks in the epithelium will get irritated. So gastric ulcer pain is worse after eating. Usually it is relieved by vomiting. And remember, the pain caused by a gastric ulcer and duodenal ulcer are usually relieved by antacids. Okay. So gastric ulcers might cause anorexia, and also it can also cause weight loss. Sometimes these gastric ulcers can lead to a perforation, which can result in persistent severe pain. Or if if it comes to a duodenal ulcer, if there's a posterior ulcer, can lead to back pain. Okay. And what are the complications? The upper GI bleeding can cause upper GI bleeding. So if they erode, or if there's a perforation, if there's a blood vessel involved, it can bleed. So there will be an upper gastrointestinal bleeding, leading to hematemesis and melena or perforation. Sometimes what will happen is when there's an ulcer, it repeatedly get healed and there's a lot of scar tissue formation. And then what will happen is there will be a gastric outlet obstruction. In rare cases, gastric ulcers can transform into cancers, gastric carcinomas. Okay, let's move on to Helicobacter pylori infection. Okay, so this H. pylori is a very popular infection which can result in gastric peptic ulcers, mainly peptic ulcers. So Helicobacter pylori is a slow-growing gram-negative flagellate. Okay, it can cause either gastritis or it can lead to peptic ulcer disease formation. It colonizes mainly in the gastric antrum. Okay, and it can be also found in the duodenum. What happens is they get confined to these gastric pits areas, and they trap all the bicarbonate secreted from these antral cells. And what do they do is they produce ammonia. Okay. And remember that this Helicobacter pylori is very much adapted to the stomach environment. Okay. And they use these different kind of adhesion molecules to adhere to these gastric pits. Okay. What they do is they have this enzyme called urease. They can convert urea to ammonium and chloride. Okay. And these ammonium and chloride compounds are directly cytotoxic. Okay. So these byproducts itself can cause a damage to the gastric lining. Okay. And it can trigger certain inflammatory and immune responses as well. Okay. So what will happen due to this Helicobacter pylori infection is it can result in antral gastritis, peptic ulcers, gastric ulcers, and also in very severe cases and severe prolonged cases, even they can lead to distal gastric adenocarcinomas as well. So what are the investigations for H. pylori? So there are non-invasive methods and invasive methods. Non-invasive methods include serological methods where you can detect the IgG antibodies. And its specificity is 83%. And carbon-13 urea breath test. It can be used as a screening test. And the sensitivity can be improved by ensuring the patient that means the sensitivity, that means the positive value, the chance of getting a positive value can be improved by ensuring the patient has not taken the antibiotics 4 weeks prior to and proton pump inhibitors in the 2 weeks before test. So these antibiotics will be learning there's something called a triple therapy where you use clarithromycin. So in order for the sensitivity to be improved, the patient must make sure the patient has not taken these antibiotics and also proton pump inhibitors before the test. So this carbon-13 urea breath test is, that means it's a quick and also reliable test for Helicobacter pylori. And actually it is a screening method. Okay. Actually this carbon-13, when it is read out, actually it is read by this mass spectrometer. Okay. So the Helicobacter pylori has urease. It can convert urea to ammonia. Understood? So what you do is, so urea is being split to ammonia and carbon dioxide. So that carbon dioxide breath is the one which is getting measured outside. Okay. Stool antigen test, higher sensitivity and specificity. And even you can go for that. But actually they require some monoclonal antibodies, and there should be a relative amount of qualitative detection, okay, of the H. pylori antigen. So for invasive methods, you can use the biopsy urease test. What where there are, you take some gastric biopsies from the gastric antrum, and you can add those biopsies to the urease and also phenol rate. What happen is, if Helicobacter pylori are present, it will split urea to release ammonia, and that can raise the pH. So phenol red will have a rapid color change from yellow to red. So endoscopy we are going to use only in patients with alarm symptoms. What are the alarm symptoms? Anemia, loss of weight, loss of appetite, melena, and hematemesis. So the treatment. So the treatment for Helicobacter pylori infections, we have this therapy called the triple therapy. We give metronidazole 400 milligrams, clarithromycin 500 milligrams, and omeprazole 20 mg. So this triple therapy is continued twice daily for 7 to 14 days. So in case of eradication failure, we are using something called the quadruple therapy. Just have an idea. And to reduce the gastric acid secretion from H2 receptor blockers, H2 receptor means there are certain receptors where you can block the histamine release. Okay, H2, where we can use ranitidine and famotidine. So those are H2 receptor blockers. Or you can use proton pump inhibitors like omeprazole, pantoprazole, esomeprazole, you can use. And it's very important for a patient who is coming with heartburn and these GORD signs of epigastric pain. And if the patient is smoking, first of all, smoking cessation is very important. And even if the patient, suppose if a patient with this rheumatoid arthritis, so if the patient is having some kind of a joint pain and if the patient is taking NSAIDs, you should prescribe either a proton pump inhibitor along with this NSAIDs, or you should try to tell the patient to avoid NSAIDs as much as possible if the patient is having these epigastric pain or pain signs and symptoms of peptic ulcer disease, known as spring. Okay, so surgery, partial gastrectomy or vacuotomy can also are also options in severe cases. So spectrum for Helicobacter pylori infections, just have an idea. It can result in asymptomatic chronic gastritis, antral gastritis, chronic atrophic gastritis, gastric or duodenal ulcers, gastric ulcers, mucosa-associated lymphoid tissue lymphomas, and also distal gastric adenocarcinomas. So guys, that's all for Helicobacter pylori infection. Remember the management, okay, is triple therapy, where you combine metronidazole with clarithromycin plus omeprazole, and there are non-invasive tests, which include the serological test and the carbon-13 urea breath test, stool antigen test, and also the biopsy urease test. Okay, and remember the main clinical features of peptic ulcer disease as well. Okay, I don't think that will be difficult because these are very common symptoms people are having nowadays. And the complications of peptic ulcer disease, which includes upper GI bleeding, perforation, and gastric outlet obstruction, in rare cases, malignant transformations. Okay, guys, hope you understood these two lessons very well. I don't think it's very difficult just by reading, or you might have heard most of these stuff in your day-to-day lives as well. So just have an idea about the points which I have mentioned and just try to revise. Okay, so if you have any questions, please mention it in below the comment section, or if you have any recommendations or anything, any suggestions for me to improve, please mention it. Okay guys, thank you very much. See you all soon with our next lecture.